Hey, welcome to This Week in Pharmacy, July 25th, 2025. This summer is going by so quickly. I can't believe this. We have a lot going on today, a lot to talk about in the news sector. We do want to focus today on non-controlled non-controls that are being diverted and how big of an issue this is. We do have a special guest to dial down into this. You won't want to let. It's Twerks, July 25th, 2025. My name is Todd Urey, founder of the Pharmacy Podcast Network. I did want to just start right out saying we do have a special three-part series that I do want to make a shout out to all of our pharmacy owners out there who are interested in expanding your long-term care at home, long-term care pharmacy at home services. Please go to pharmacypodcast.com, go to the news section, three-part series by Icon RX Safe. This is a wonderful breakdown of what it means to become a paid long-term care at-home pharmacy provider coming out of your community pharmacy, and some of the resources that you already have will be leveraged. And then, of course, all of the parts, the entire puzzle will be here for you to listen and understand what it takes to become a long-term care pharmacy at home provider. We want to give you as many resources as possible. And I'm excited about this series. So please take a listen. Let me know what you think. And reach out to the RX Safe team. They do a great job in guiding our pharmacy owners to profitability. All right. Twerks News today is brought to you by Independent Pharmacy Cooperative, giving independent pharmacies the freedom to farm. Great organization. We just got back from IdeaShare, McKesson IdeaShare. You'll be hearing a three-part series that will start next Thursday, July 31st, last day of July. That's my wife's birthday. Happy birthday to Nicole next week. Big party time. Let's do it. But today, news. First, let's talk about Pharmacy Podcast Network. Have you heard the latest from GRX Marketing Against PBMs, a March to a Million? This is an amazing episode that combines some of the insights of their team and the medical mafia, the modern medical mafia, and the Netflix special, as well as some of the programming. And a shout out to Bill Schmitnick and his efforts, and the story of his lost son, Cole, because of a PBM and chain pharmacy disaster. You just listen into this. This will give you some perspective of how to fold a march against PBMs, and it's a great story. Also, the series I just told you about, the last part, Not Your Average Joes, two rock stars in our pharmacy community, Joe Moose and Joe Williams, are talking about how they're expanding, how they're building their long-term care pharmacy business at home. Opioidology, Part 1, our opioid story. This is from Dr. Mark Garofoli, the pain guy, hashtag pain guy. Great episode to kick off this three-part, multi-part series on opioidology. Please definitely take a listen. And expanding holistic pharmacy services, integrated pharmacy services. This is a great episode from Marina Buskov, Dr. Buskov, and Dr. Swathi Varanasi. We haven't heard from Swathi lately, so it's great to hear her back on the Pharmacy Podcast Network. Hey, Surecast is a new podcast from the Surecost team, breaking down the true cost of purchasing through one wholesaler exclusively, and not having the balance of resources and data to guide you as a pharmacy owner. And this is going to be a really interesting series that we're doing with the Surecost team. You have to listen to part 1 and part 2 that's out now, and there will be links in our show notes. All right, like I promised, Alan McGill is a Senior Supervisory Special Agent. He's currently signed to the Office of Public Engagement in the state of Pennsylvania, and this is part of the Attorney General's department and program. I've known Alan for years, and he's going to give us some insight into non opioid, non controlled substances that are being diverted, and how there are issues with that. Before we get into that, did you hear there is a pharmacist that used to work for Walgreens? This made national news on CNBC. I don't read much of CNBC's news anymore. I really follow them more on Twitter, but I did come across this really fun story, and it's a shout out to a pharmacist doing something different. But the headline is she quit her job as a Walgreens pharmacist to start a Vietnamese coffee company, and today it brings in over $500,000 a year. This is quite the success story from Dr. Lan Ho, founder of Fat Milk, and it's MIILK. And she was working as a Walgreens pharmacist, earning about $120,000 a year. She built this coffee company, and now it's exceeded $500,000 a year. And it just shows you that your passion is not limited by a pharmacist career. If you want to get outside of pharmacy, but use all of your connection to your background and your network, this is an exciting story. So this came once again from the news just this week, and excited to watch Lan Ho do more. Dr. Ho, maybe we'll have you on Twerks, talk to us about coffee. I love coffee, so that'd be a good episode. Hey, this coming off of Fox News, and the headline is Pharmacy Chain Closure. 114 stores closing in the state of Pennsylvania. That's my state, been hit very hard with the closure of Rite Aids and the impact that's going to have on public health. Something more in the good news is the next that comes from Yahoo Finance. The title here is Clover Health, publicly traded CLOV, announced a new pharmacy pilot program in New Jersey. We heard about this a week ago from our sponsors, IPC, and their iCare Plus program. But this program is aimed at helping seniors. It's a management that noted the local pharmacies that are using iCare and are part of the iCare network will be the backbone of the initiative, and how using this platform to dig deeper into patients' needs and more around seniors' needs through remote patient monitoring and telehealth is going to be a huge part of the future of our independent community pharmacies. But this made national news. The Clover Health system and plan is now inserting iCare Plus into it, and that is a huge, huge, huge win for our independent community pharmacies. If you're interested in learning more about iCare Plus, please take a look at IPC's site. Just go to ipc.com. Once again, that's ipc.com, or ipcrx.com, that is, ipcrx.com. But wonderful news from Clover Health, and as a program embedding community pharmacy into it through technology that they have through the iCare Plus program. All right, last news that just came out today from the NCPA, National Community Pharmacists Association, applauds a bill to reimburse pharmacists for treating COVID, flu, and other ailments, and how Doug Hoy was quoted saying that this legislation protects patient access, especially for people in rural areas where pharmacists can be the only healthcare provider for many miles. And independent community pharmacists delivered tens of millions of doses of COVID-19 vaccine during the pandemic. They saved the lives of countless Americans who would not have gotten the vaccine without them. The legislation expands on that success, and this is called the Equitable Community Access to Pharmacist Services, the ECAPS Act. and it was put into motion through the efforts of Senator Mark Warner and Senate Majority Leader John Thune. And this is good news for independent community pharmacies. Shout out to you. Last on our news comes from RX Insider, and it says Consorti X, state of the nation, state of the industry, leveraging DSCSA to improve operations, and how it's important with the recent FDA town hall, which was hosted in advance of the coming wholesaler enforcement date. And this date will go into effect as of August 27th, 2025. It's coming up very soon. Once again, if you want to learn more about that, go to rxinsider.com and go to their product awareness section. And it's an overview. It's a webinar that's done out by Consorti X. And just a shout out to them for keeping us informed. And we'll be doing more with RX Insider coming in the future, leveraging a lot of the reports and insight reports that they're doing, including a follow-up to the careers report that we reported on, the report of the report of the report. How many times can I say the word report? Goodness gracious. But yeah, that'll be exciting to extend that information that we're getting from the RX Insiders team. I do want to just say a special thank you to Alan McGill. He drove from Erie, Pennsylvania, down to our studios in Brownsville. That's about a 2.5-hour drive to do this update on non-controlled substances and diversion, and how important it is to be aware of that. While controlled substances are typically the focus in drug diversion discussions, several non-controlled medications also pose significant risk for misuse and abuse. And due to their unscheduled status, these drugs are often subject to less stringent monitoring, despite growing evidence of non-therapeutic use, dependency, and harm. Many of these medications are routinely stocked and administered in veterinarian clinics, and ongoing misuse could result in future scheduling or increased regulatory oversight. Non-controlled drugs with known emerging potential misuse or abuse, and we'll have some of those that are included from this interview with Special Agent Alan McGill, Senior Supervisor Special Agent, currently assigned to the Office of Public Engagement. This is an amazing update, and we're excited to bring this to you on This Week in Pharmacy.
One of the things that had come up, and I was doing trainings for hospital systems and for pharmacists, and I've been doing it since 2012, I think, is how long I've been doing these presentations and trainings. And I was at a hospital system in northwestern Pennsylvania, and I was doing a training for their staff. And after the training was over, the pharmacy manager, the pharmacy director, had come over to me and said, you know, Alan, I have a shortage of promethazine. And can you explain why somebody would want that? And I said, are you talking about promethazine with codeine? And which is a common drug for, students and schools. You know,
Okay.
I mean, it's also makes its rounds in the celebrity circles and those sort of things too. You might commonly think of it under nicknames like Lean or Scissor or Purple Drank, things like that. And so I had asked her, I said, is that what you're talking about? She said, no, I'm just talking about straight Prometh. And she said, can you think of any, because you can't get high from it. So she said, can you think of any reason why somebody would want to steal that? Because I have a shortage of it in the pharmacy here at the hospital. And I said, well, the only thing that comes to mind is that is something that will alleviate at least one symptom of withdrawal. And so since withdrawal symptoms are, they're very painful, somebody that's experiencing it, going through it. So, and nausea and vomiting is a part of that. And so promethazine treats that. And so what I'd said to her is, like I said a moment ago, is you probably have somebody on staff that is suffering from a substance use disorder. They're trying to self-treat. And so they're they're stealing the promethazine in order to do that. And that's been a common thing that I've had occur during a lot of the investigations that I ran, where you would have a pharmacist or a healthcare professional, a nurse, whoever it is, that tries to self-treat their substance use disorder. They don't want to be discovered. They don't want anybody to know. They don't want to risk their job. And so they will take just about anything, and they'll get into the polypharmacy a little bit. And this occurred with a pharmacist that I had arrested as well. And I hadn't really thought about it a whole lot when I initially started doing the trainings. I mainly focused on the controlled substances and stealing those, security measures to put in place to make sure we can account and track for those. And I had arrested this pharmacist, and a couple of years later, I had asked her to do a on-camera interview with me so I could use it in my training segments. And one of the videos that she did, she talked about that. She had developed a substance use disorder to the point she'd become addicted to Vicodin, and she was taking Vicodin in 10 at a time. She would take a handful and use 10 at a time. And she would do that sometimes 2, 3, 4 times a day. So you're talking about 40 pain pills that she was taking. So that was not something that was that unusual in the diversion end of things. But what I found interesting in her video, and I play this video a lot when I do trainings, she talked about how there was one point where she was at the register and she was nodding off. She couldn't keep her eyes open because she had taken so many of the opiates. And so she ended up looking for a way to counter that, and she decided she would take Provigil, for narcolepsy. And so, to get her, she said, but then her heart started thumping, just pounding away. So she took blood pressure medication, which is a non-controlled. So she takes that, and then she, dipped into the benzodiazepines, and she went through this whole litany of different drugs that she had tried. And one of the things that I also, I point out to a lot of folks is that, when it comes to healthcare practitioners, they're very often therapy indicators. They know what the drugs do. They know, what the effects are and those sort of things. So they're comfortable taking it and trying to treat themselves. And this happens a lot with people that suffer from substance use disorder. They don't want to be discovered, so they're looking for a way to counter that. And so going back to the promethazine, that was, I think, was one of the things that was happening. And interestingly enough, I was just, when I was doing this presentation at NASCA, I was talking to one of the prescription drug monitoring program directors out of South Carolina. And she said they're having an issue in South Carolina where they have individuals that are actually illicitly obtaining it from pharmacies. And I think one of the things that happens is that we get so focused on guarding the controlled substances, we sometimes ignore the non-controlled. And the non-controlled can just be a clue. Now, I should say, I'm not suggesting this is widespread or this is an epidemic or anything like that. I'm just pointing out that non-controlled can be a marker to detect if you have someone with that condition, which can lead to maybe undiscovered diversion that's occurring in your facility. So as an investigator, it's worth paying attention to. If you see something, like that pharmacy director asking me about, Prometh, was an important clue that they have an issue there. So in South Carolina, what they have is a lot of the pharmacies are pulling back dispensing promethazine with codeine. And the reason that that's occurred is there was a progression in this. When I was still in diversion, when I was a supervisor, we had some groups that were traveling across the eastern seaboard of the United States that were going into pharmacies, and they were either illegally calling in promethazine with codeine or they were forging prescriptions. And what had happened was they would do that. The pharmacies would catch on. They would call law enforcement like us. Then we would post up somewhere around the pharmacy and we'd wait for them. We'd snag them when they came in. So, criminals are always thinking of a way to get around whatever measures we put in place. So what started to happen was then instead of calling it in and alerting anybody, they started showing up more and more towards the evening hours, especially when the pharmacy was about ready to close, so that law enforcement wouldn't get the heads up or get the advance to arrest them. And then they just started jumping counters. They started just going over the counters and putting pharmacists at risk.
Yeah.
So a lot of the pharmacies didn't want to carry promethazine with codeine. For one thing, it's easy to see, and street value can go as high as $1,000 a pint. Sometimes a lot less, just depends on the market, but it can go that high. So if you think about it from a gang or criminal gang's perspective, if you see 3 or 4 bottles up on a pharmacy shelf because it's only a Schedule 5 and you see it sitting there, that's easy pickings. That makes more sense to go jump that counter and take those than it would to try the safe systems that they have in place and those sort of things. So in order to counter that, a lot of the pharmacies were stocking promethazine with codeine. And what they found is now they have to revert to straight prometh. So what a lot of the individuals are doing is they'll look to gain access somehow illegally to the promethazine and then just combine it with another drug outside of that. So they can mimic that street drug. So those are, that's something. But the main thrust of what of this presentation or what I talk about is if it alleviates any symptom of withdrawal, symptom of withdrawal, then it's going to be a drug that's going to be subject to being stolen. And so it's something to kind of pay a little closer attention to. There are lots of drugs, including the non-controlled, that can potentiate the effects of controlled. And so that becomes another reason too, to look for this. I can remember talking to patients at the methadone clinic in Erie. And at that time there was, I forget what drug they were after, but I asked them, I said, why are you doing that? I think it was bug spray or something. And I said, why are you messing around with bug spray? And they said, well, as doctors have pulled back on how many medications they prescribe to us, we're still addicted. And so they're looking for anything that could potentiate the effect of an opioid or a benzo or another drug that they have. And so they'll go to a non-controlled. And of course, with the internet today, people can go into chat rooms, they can go into just do Google searches, and they can find those kind of things, and they can learn from each other. So that becomes another reason that they do it too. So, alleviate any withdrawal symptom is my, so what I tell pharmacies or pharmacists is, the drugs better than we do. I'm just a dumb cop. So I have to catch up, I have to learn as I go. Whereas they know what the drugs are and what the new ones that are coming out. So if there is a drug that is going to potentiate the effect of a controlled substance, or if it can alleviate any withdrawal symptom, then that's a drug to pay attention to. That if it becomes up missing or you have shortages, that can be a clue as to maybe you have an issue or a problem within your system. And so it's just something to kind of pay attention to that way as well. And so, withdrawal symptoms can, they vary, of course, from, and I would say probably the ones I paid closest attention to are opioid withdrawal, benzo withdrawal, and then stimulant withdrawal. And so, they're pretty similar, but, they're all about the same. But there's a few things that kind of go out of that. So looking for those kind of things is what you're after. When it comes to hospital systems, just some of the drugs that they're usually we're trying to encourage them to pay attention to, for example, would be like propofol. Propofol is not a controlled substance. And not surprising, the vast majority of shortages of propofol are going to exist with anesthesiologists or CRNAs. So, just paying attention to those. As I already mentioned, straight prometh is another one. Onidestrin or Zofran is also one that is used to treat nausea and vomiting, generally thought of in circles of chemotherapy and those sort of things. So that's going to be one that could be subject to be stolen too. And, part of the other problem is it's probably not going to be stolen in large quantities, so it might be easy to miss, that sort of thing. So, but it can be, something to pay. And then methyl naltrexone or Relistor is another one too. Now that's used to treat opioid-induced constipation. So also something very uncomfortable. So, and, depending on costs of different drugs like this one could be expensive. So you might have individuals inside the system, the healthcare system, that say, this is something that, I want to take in order to alleviate, that point of withdrawal as well. And along a similar line, another one that comes up, it's come up a couple of times, is loperamide or Imodium.
Okay.
I have a friend of mine. She's a CRNP at the VA, and she had told me I think it was about 6 months ago, that a patient had presented and he admitted to taking 200 milligrams of Imodium every day to get high. Because if you take it in large quantities, you can get a reaction, get high from it. 70 milligrams is supposed to be on the high side. So imagine taking 200 milligrams. And the other thing that this does too is, individuals that, are looking to treat, some sort of symptom, but they're also not in any danger of getting arrested, at least not theoretically, because it's not a controlled substance.
Yep.
And so because of that, that's another reason they want to do it too, because they don't have to worry about getting arrested, but they can achieve the same effects. So that's one and we've had to come up a couple of times, oddly enough. It came up a couple of years back, and I kind of dismissed it as a one-off, but now when you hear it again and you start hearing a couple more cases across the country, it's just something to pay attention to. When I train law enforcement and I do anything along those lines, especially if it has to do with patrol or even during search warrants, if you walk into somebody's house and they got boxes of Imodium, then you clearly have got somebody with a substance use disorder. And it could be anything where you walk into any kind of situation and just notice that. So it's just things to kind of pay attention to. Another one, Seroquel, is one that is also subject to be taken well, and it could potentiate the effects of benzodiazepines.
Okay.
So, if you have someone that develops an addiction to a benzo, such as, Xanax or Valium or any, Ativan or something along those lines, and they're suddenly getting weaned down from their doctor, or, they're not getting as many as they used to get, or however they want, and they can convince someone to prescribe them Seroquel, then they can potentiate the effects of what they already have in existence. And the other thing too, and there can be a market for this, even though I said, really, I don't expect it to be widespread or high volume of losses. But one of the things that folks do that have a substance use disorder, especially on street usage, is, this becomes currency as well. So if they can steal a bunch of it and they can trade it for another drug of choice or something like that, and people that want to maybe have something on hand in case they can't get as much as they want, it becomes another reason to do that too. Another drug that, and I included in the presentation, is called Atizolam. And so Atizolam is actually emergency scheduled right now. I think it still is. I'd have to double check it. But Atizolam is an illicit benzodiazepine that is not approved for any medical use in the United States. And we started to see it show up in different forms. One form was in counterfeit pills. And so they would take Xanax bars, and instead of having it have any Xanax, it would actually have Atizolam instead. And Atizolam is not a safe drug in the United States. So, and then another form that we had in the central part of Pennsylvania was we had a case involving, and this was when I was still a supervisor. A woman had purchased a gentleman had purchased some out of New York City, some pills, and they were actually Pez candy, and they were coated with Atizolam. And he had given them to a third grader and a sixth grader, and they almost died. He was babysitting. He wanted them to go to sleep. They had a lot of energy, these two little girls, and he thought it'd be a good idea to give them each a couple Pez candy coated with Atizolam. So, it's just, but it's not a regular, it hasn't been confirmed. It's just been emergency scheduled. Wellbutrin is another one that comes up from time to time as well. So that one, it has, it's an amphetamine analog, so it can have similar stimulant effects. It's another one. One of the things that I noticed, and like I said earlier with my example about talking to, folks at the methadone clinic, what they will tell you is they'll take anything. And this is true for healthcare professionals too. They're going to be willing to take anything to avoid withdrawal because it's so painful. So this can be a stimulant, it can be a benzo, non-controlled, whatever it is. One that I think is particularly attractive of a non-control is clonidine. Clonidine will actually treat all of the symptoms of opioid use withdrawal.
Okay.
And so, if you're a medical professional and you have access to clonidine and you're going to start suffering through some sort of withdrawal, then that can be something that'd be attractive to take as well. And then, of course, we have gabapentin, which is a non-controlled. Now, depending on how far out your listening audience is, there are some states that do have it controlled, and some states actually have it where it is his requirement is that dispensing is uploaded to their PDMP, their prescription drug monitoring program, which I think is a good thing.
Mm-hmm.
We don't have anything like that in Pennsylvania that I'm aware of. So, gabapentin is one that is widely abused, and most people are pretty familiar with that now.
Mm-hmm.
It's also a drug that is used in the veterinarian space as well, because it's very effective painkiller for dogs and cats. And so that's another drug that we keep an eye on too. And then just some ones that, one that comes up all the time that I probably should mention too is kratom.
Okay.
Kratom is not an illegal substance. It's not regulated by the FDA or anybody else. But the problem with kratom is there have been cases across the U.S. where there have been deaths associated with kratom. Now, people that are pro-kratom are going to tell you that, it's not, there have been no deaths by kratom itself. And that could be true. I don't know that. I just know that there have been cases where it has come up in the toxicology where they have kratom in the system.
Mm-hmm.
The other part of the problem is because it's not regulated, how do we really verify what's in it?
Mm-hmm.
So, you right here could be a kratom manufacturer, produce your own kratom in this little studio if you wanted to, and press them into pills, and there's no regulations on it. So, how would I verify that what you're selling me is actually kratom and not tainted with something else?
Right.
So, and then of course, the one that everybody is really familiar with, of course, xylazine, which is the veterinarian medication that everybody thinks of as the zombie drug that gets mixed in with fentanyl a lot, and that's true. That's emergency scheduled by the DEA too. So I don't usually talk about that, but the newer one is medetomidine. And so medetomidine is also another veterinarian medication that's used to treat animals. But we're starting to see that show up in samples, especially out east in Philadelphia and those areas. So medetomidine becomes one. So individuals that are looking maybe for clues as to individuals looking to sell or make money in that space, that's what we would look at. So really, there's a whole wide variety of different controlled substances, but what I would say and what I encourage pharmacy directors and pharmacists is, the drugs better than we do, and just pay attention to the ones that can alleviate any sort of symptom from withdrawal, even if it's a non-controlled, even anything at all would be helpful to help detect diversion.
Have you, over your years, developed a reputation in a network of pharmacists and pharmacy owners who will reach out to you on occasion to ask your advice on something that might seem strange to them?
Yeah, they do occasionally, but generally, since I've been in this unit for a while now, they'll usually contact the diversion unit with the Attorney General's office, or they'll contact the diversion agents in the DEA, because DEA has their diversion agents too. I'm not so much talking about the tactical diversion unit, but just the diversion agents that go out and do inspections and also enforce those, the CFRs too. So it's waned off a little bit. I do have people that contact me from time to time to ask me about, I just had a doctor, for example, call me the other day about, he was involved with a physicians group that prescribes ADHD medications, and the pharmacies, for whatever reason, had a little bit of a concern about it, and so they weren't filling his prescription. So he was calling to ask my advice on that. I get pharmacies that'll call and ask, different questions about, any new regulations, telemedicine, those sort of things that are coming up.
And working with the Attorney General, are you able to, based on data, are you able to start seeing trends appear in certain parts of the state, and then kind of like flags your team to make pharmacists or pharmacies aware of something that might be happening?
Well, We don't have anything in place right now that I'm aware of. Most of the time that will come from the prescription drug monitoring program. So they do have ways to alert pharmacists in the prescription drug within their system, so they can look there. So they generally do that. We pass on what we can to pharmacies, whenever we can. For example, one of the things that's been coming up recently has been, the rise in the psychedelics.
Okay. Yep. We're hearing a lot about it.
Yeah. So the psychedelic space, there's a lot. And I think I had warned people probably about 2 years ago when we started to see the more accepted medical use for it, which, is great. I have no issue with that. But the warning is that when you see that, you're going to see more of it illicitly.
Mm-hmm.
Not worried too much about diversion in terms of how it's administered, as I understand the process. So I'm not too concerned about that. But just the fact that it's going to show up more on the street. There's going to be a demand for it. Individuals looking to make money are going to make it available in all kinds of forms.
Mm-hmm.
And that's what we're starting to see. We're starting to see that more and more.
All right. So what's the best way if someone's listening to you and they do want to reach out, they want to get more information? Can we share your email address up here?
You can. The only thing about that is probably the better way is to contact our office, the Attorney General's office.
Okay.
I tell folks all the time, you can call me, but I don't investigate cases anymore. I just do trainings and presentations. So, I just try and impart knowledge as best I can in crime prevention. And what will happen is I'll have to hand them off to somebody else.
Yep.
So you can show my email. It's fine. They can see it. They can certainly reach out to me if they have a question or an issue. I will, quarterback that and get them to the right unit, that sort of thing. So if they want to skip that step in the process and go right to the source, then they can contact our office directly and just look for any Bureau of Narcotics investigations local. There are 8 across the state, so they can contact any one of those and they'll put them right to a diversion agent.
All right. So I don't expect you to have a crystal ball, but being a fellow Pittsburgher, area-ist, and I guess is a word, doesn't even mean, but you are a Steeler fan. So what do you think is going to happen this season?
Actually, I'm not.
Oh, I thought you were.
No, I'm not. No offense to the Steeler nation, and I know they're going to cringe when they hear this, but I'm actually a Cowboy fan.
Oh, okay.
So ever since I was a kid, and really Roger Staubach is how it got me into that. But ask me your question about the Steelers. I'm not anti-Steelers. I'm
looking forward to the recreation of our team this year and just adding some new players in, and I'm nervous. I don't see like anything. I'm not going into this season like I've gone into seasons 5 and 10 years ago.
It's really hard, I think, probably without having a leader quarterback, having a defined, Ben Roethlisberger was here for so many years that it became sort of just, I think you take it for granted.
Exactly.
And all of a sudden when someone like that, of that caliber and that talent is not there, then who's going to fill that void? And so I don't honestly know. I don't even know. Did Aaron Rodgers officially sign?
I thought so, but then I read something else that there was some other negotiation happen. But I think he'll start for us.
That's going to be an interesting dynamic, to see that happen. I'm curious about that, and I have to say, just from a fan's perspective, it may not be a popular opinion. I'm kind of looking forward to seeing that.
Yeah.
So, because obviously he has great talent. So, I mean, he was on the downside of his, his career, but we'll see how it goes.
Well, we appreciate you coming down from the Erie office and Meadville area and driving down to the studio here in Brownsville. You're welcome to definitely do a follow-up. I got to get up to the national association that you actually helped command in order to get some pharmacists more involved there. What's the next event that will be taking place?
We did a drug diversion and healthcare conference this past April. It's a local one that our office does with an organization called BCAT, which stands for Brockway Center for the Arts and Technology. And BCAT actually is a nonprofit that what they do is they provide pharmacy tech certification and schooling for free. They only take, I think, about 15 students per class, but it's mainly folks that, they provide this service and you have to apply and then you can become a pharmacy tech. And they have, I think, a good job placement program. And then they also do medical assistant and phlebotomy, which is really interesting. So I was doing presentations for their pharmacy tech students for a number of years. And the executive director, Derek Hansen, and I, we had, and his lead instructor, Jessica Hummer, we had gotten together and talked about doing a conference. And so we had our third annual conference in Erie, Pennsylvania. It was, did very well. We had over 200 people registered, and we had 180, I think it was 185 people actually attended the conference. And so it was just a one-day event. It was a great event. We're looking to do it again next year. We're not entirely sure. We did have it at Pitt Titusville for the first couple of years. And it's a beautiful campus. It's a great place to have it, but there just isn't any the infrastructure, the hotels, or a good route to get there. So it was a little bit harder. So we only had about 120 people who would show up at those. And so we moved it to Erie. We had an explosion in the number of attendees and had a lot of great subjects. And then this year we're looking to put it, and I'm not really sure, we may go back to Erie. We're looking at Grove City area, somewhere that, because of 80 and 79, because of that intersection there. So we're thinking about doing it somewhere around in there. Our Attorney General, David Sunday, came out and spoke for us there. Fantastic lecture he did for us too, for about 20 minutes to open it up for us. And he's really super. I don't know if you had a chance to meet him or hear him speak or anything. He does he's really a down to earth guy. And at the risk of sounding like I'm sucking up to the boss, I'm going to say I've been with the office for 27 years. I've worked for, I think, 8 or 9 attorney generals. And he's by far the best one that I've seen so far. Yeah, he really, really admire him. He has a great campaign. He campaigned on what he calls accountability and redemption. Those are the things he believes in. And I really like that, because as a diversion agent, one of the things that I always talked about was trying to get people help, because the vast majority of healthcare professionals are not criminals. They are people that fall into a substance use disorder, and they end up crossing lines they never would have imagined. They're not bad people. And so, but we have to hold them accountable, and there has to be a redemption. We got to get them to the point where we get them back so they can get their careers back. And so I built my career on that premise. So when I heard him talking about that and expressing that, I thought, well, finally, I've got an attorney general that, I'm proud to really work for. And so I'm really happy about that. I'm excited to see what he's going to do over the next 4 to 8 years. And, he's just a good guy. Hopefully we can get him down here and have a conversation with you, or maybe even on a Zoom or something.
Right. So absolutely. Alan McGill, this has been terrific. Thank you so much for being on This Week in Pharmacy.
Thank you very much for having me.
Hey, This Week in Pharmacy listeners, we will